All right, good morning. So I'm going to be talking over the next 20 minutes on some of the newer therapies that are available for acute leukemia. In recent years, there have certainly been a lot of new drugs approved in the world of CLL, as you just heard about, and multiple myeloma. Unfortunately, in acute leukemia, there haven't been as many advances over the years. When you look at AML, which is the most common type of acute leukemia in adults, when you look at how we treat this, we are still using the same type of chemo regimen that was developed in the 70s. It's older than I am. And so we certainly have a long way to go. And I'm glad that Dr. Venetoclax has addressed how important clinical trials are, because a lot of the drugs that I'm going to be talking about today are actually currently in clinical trials. All right, so just to take a step back, when we look at leukemia, so this is how our blood cells normally go through the maturation process. And so you have your myeloid and your lymphoid stem cells. And what happens in acute leukemia is these cells lose their ability to differentiate. They can no longer mature. So they stay at this very immature stage. And because of that, these cells are proliferating uncontrollably, and that crowds out your normal blood-making cells. So this is a very simplistic approach to acute leukemia classification. Really, when you talk about AML and ALL, the two main types of acute leukemia, these are really umbrella designations. What we've learned over the years is that every leukemia is unique. There are different DNA changes that occur, there are different genetic mutations, and so we really do have to take each patient with acute leukemia and tailor our therapy to them. What we're going to focus on today is mostly the AML designation. So de novo AML is an AML that arises out of nowhere. You were perfectly fine and all of a sudden you become very ill and you have blasts in your blood, those immature cells, and probably not making much of the normal cells at this point in time. Now there's also a big category called secondary or therapy-related AML. So these are patients that have been treated for other cancers or have other blood problems that then transform into AML. And then a brief talk on B-ALL. So when you look at the treatment of acute leukemia, what we do now, generally we're using multi-agent chemotherapy regimens. When you look at AML, the most standard induction therapy that we use is something called 7+3. 7 days of infusional cytarabine, which is probably the most important drug we use in AML, with another drug for 3 days called an anthracycline. More recently, we have been using some lower intensity chemotherapy agents called hypomethylating agents. These are not currently FDA approved for the treatment of acute myeloid leukemia. They are FDA approved for myelodysplastic syndromes. But what we have found is they are very effective in the treatment of AML. This has allowed patients who previously were thought not to be candidates for chemotherapy to actually receive treatment for their acute leukemia. And then when you look at ALL, for the younger patient population, generally those patients under the age of 40, we are using very complex pediatric-inspired chemotherapy regimens. These are the most complex chemotherapy regimens that we have in cancer. And so you definitely want to have a physician who's very well-versed in these regimens. And then the hyper-CVAD regimen is one that we use more in an older adult population. Now, while some patients can be cured who have acute leukemia, not all patients who have an acute leukemia will respond to our standard therapies. We use a lot of information that we gather at the time of diagnosis to help put patients into risk categories, to help us determine what is their best treatment options. This is also help identifying those patients that may have a mutation that may be eligible for one of these newer agents in a clinical trial. So we use cytogenetics, like a DNA analysis of the cells, and the mutational analysis, which you heard a lot about earlier from Dr. Khan. So the first drug that I want to talk about is one that we are hopeful is going to be approved here in the next several months. This is a drug called CPX-351. And this is being positioned for patients who have secondary or therapy-related acute leukemias. And so when you look at how these patients have done previously with standard chemotherapies, they have lower response rates, and they are not likely to survive as long as patients who have a de novo or a new AML. What this did was it took our old drugs, cytarabine and daunorubicin, and it basically repackaged them to be more effective. They've mixed these two drugs within something called a liposome. I like to call it like a fat bubble. But what this has allowed is you get better penetration into the bone marrow. And obviously with acute leukemias, the problem is in the bone marrow. So this helps get that drug into the space where we need it the most. This has been a very effective drug. When they compared this on a clinical trial to the standard 7+3 regimen, the response rates were better, their survival was better, there were better rates of stem cell transplantation. And what was most striking is this was seen even in the patients that were aged 70 to 75. They were able to go to transplant more often, but they also had improved outcomes after transplant. So again, 5 years ago, this may be a patient population that wouldn't even move on to stem cell transplant because they either didn't respond or were so beat up from the chemotherapy that they weren't eligible for transplant. This may provide an option for patients to have more tolerable, more effective chemotherapy. Venetoclax, so this is something Dr. Binu alluded to in CLL. So this is a drug that's being used in a lot of different blood cancers. And again, this is not necessarily a targeted agent for AML. So BCL2 is a protein in the cell that regulates apoptosis, which is cell death. This is showing efficacy not only as a single agent, but it's also being evaluated in combination with the hypomethylating agent therapies. So these low intensity options, again, expanding our ability to treat older patients with a very bad disease. Now, Dr. Khan talked about some of the mutations earlier in the talk. The ones that we most commonly check up front, and this is likely to soon be very much expanded because you can see there's a very wide range of mutations that you can see in acute myeloid leukemia. But the three most common that we check up front would be FLT3, NPM, and CEBPA. I'm going to focus mostly on FLT3 because this is the one that has had significant improvements in the number of targeted therapies that are now available on clinical trial. So FLT3, what FLT3 stands for is an FMS like tyrosine kinase 3. So this is something that is in the membrane of the leukemia cell. And there are two different types of mutations that you can have in AML. About 30% of AML will have a FLT3 mutation. The more common one is the ITD mutation, which is located here, where you get repeated sequences of DNA. And so this causes a dysfunction of the FLT3. You can also have a tyrosine kinase domain, a TKD mutation, which is just a point mutation where just a single amino acid is changed, and that occurs down in this area. Now, Midostaurin, this is a drug that was just approved within the last few weeks for FLT3 positive AML. So this was very exciting because it has been quite some time since we've had a new acute leukemia drug. Right now, this is going to be used for patients with AML with FLT3 mutations, either the ITD or the TKD mutation. It does work for both. And it's being used in combination with standard chemotherapy. So on the clinical trial, it was combined with the 7+3 induction regimen and then 4 consolidation therapies with cytarabine, which is our standard OFFA protocol. This trial was significant because it did improve overall survival and decrease the amount of relapses that we saw in this high-risk AML population. Interestingly, when you looked at the responses after induction therapy, so when someone goes through the chemotherapy, we want to check to make sure it works. At that point in time, there was actually no difference in response. So the benefit of this drug was actually the long-term effects, keeping these patients in remission long-term. Now, this is a drug that's been in development for a very long time. I was fortunate enough to be involved in the RATIFY study, which led to this approval. I put my first patient on that trial in 2008. And so you can see this just now 3 weeks ago finally came to fruition. And luckily, I also have patients on that trial who are still alive and well without disease, which is remarkable, again, with a high-risk AML patient population. Now, midostaurin has a lot of other targets besides FLT3. And I think that that's one of the reasons for its success, is that we're probably targeting some of these other mutations in AML and not just FLT3. There are some other FLT3 inhibitors that are in clinical trial. First, I want to mention sorafenib. So again, you heard about sorafenib earlier. This is a drug that is FDA approved for liver cancer, but does have efficacy against FLT3 mutations. This is something that I've actually been using off-label for my patients who have a FLT3 mutation. Luckily now I'll have another option to offer them. Now these other three drugs, these are currently in clinical trials. Quizartinib is a FLT3 inhibitor that has a very narrow range. So it really targets just FLT3, and it's specific for the ITD mutation. So only patients who have the one type of FLT3 mutation can go on these trials. One of the trials that is being done is a phase 3 study where it's modeled very similarly to the midostaurin trial, where they're adding quizartinib to standard induction chemotherapy, followed by consolidation chemotherapy with cytarabine, and then there is a 1-year maintenance after the end of consolidation. And this is versus our standard of care, which is induction, consolidation, and then just observation. Gilteritinib is another FLT3 inhibitor that has several studies that are ongoing. One is similar to the one I just described. This is for patients who have both FLT3 ITD and TKD mutations. One of the studies is, again, adding it up front with induction and consolidation. There's also a study that is using it as a maintenance. After you've finished standard therapy, you can then go on this drug as a maintenance. And then there's one in the relapse setting. So someone who's previously been treated has the disease come back, and they do have a FLT3 mutation. And then crenolanib is another one that has similar clinical trials ongoing. Now, there are other targeted therapies that we're using in AML. Again, you heard, luckily earlier this morning from Dr. Khan about the IDH 1 and 2 mutations. These mutations are present in about 20% of AML. The IDH1 mutations are slightly more prevalent than the IDH2 mutations. And there are some targeted therapies in clinical trials currently. There's one, AG120, which targets IDH1 mutations, and AG221, which targets IDH2 mutations. Both of these are being looked at in patients who have previously been treated for leukemias, but have had their disease come back. And something earlier on is now a medication, AG881, which actually is going to target both IDH1 and IDH2 mutations. All of these medications are oral drugs, so if you have someone who is not in maybe as great a health, this is certainly still an option for them. Now, Vadastuximab is a drug, so this is a different type of targeted therapy. So with the IDH2 mutation, or the IDH1 and 2 inhibitors, the FLT3 inhibitors, these are more small molecule medications. Vadastuximab is an antibody therapy. And so what it is it's an antibody that then is linked to a toxin. So in this case, the toxin is something called PBD. Now the antibody portion of this targets a marker on the AML cell surface called CD33. So all of these cells have a particular pattern of expression on their cell surface, and CD33 is one of the common ones that we see in AML. So this antibody can attach to the CD33 on the leukemia cell surface. This whole complex gets taken into the cell where the linker, this middle portion, gets broken away, which releases the toxin into the cell. This toxin then causes DNA damage, which ultimately leads to the death of the cell. And so again, this is targeting specifically these AML cells. This drug is very similar to an older drug that had been on the market, something called Mylotarg, but the toxin that this uses is a little bit different, so the toxicity profile seems to be a bit better with this. Now, just to kind of wrap up with a little bit on acute lymphoid leukemia, Obviously, this is an acute leukemia that we more often see in children's and adolescent, but we do also see a second spike in older patients. Now, there are some targeted therapies that are currently in use that have been around for a bit longer. Rituximab is something that is used not only in non-Hodgkin's lymphoma and CLL, but also in ALL. This targets CD20, again, one of those markers on the cell surface. And then there is also a subgroup of ALL that has a particular cytogenetic change called the Philadelphia chromosome. And this is the same chromosome abnormality that can be seen in chronic myeloid leukemia. And so we're lucky that we have many drugs now that target the Philadelphia chromosome, imatinib or Gleevec being the original one. But now we have a whole series of these, and we do use these in combination with traditional chemotherapy to improve our outcomes and our response rates. Now, one of the newer drugs, this is one that is currently out on the market called Blinatumomab. So this is a brand new type of drug. This is something called a BiTE molecule, which stands for bispecific T-cell engager. And so you've seen the picture of the antibody before. What this particular medication does is it just takes part of the antibody and combines it in a small molecule. So one part of this antibody targets CD19, which is a marker on BALL cells. The other part of this molecule targets CD3, which is expressed on our cytotoxic T cells. So these are immune cells that are able to kill other cells. And so what you're doing is basically waking up your immune system, saying, hey, here's a cell, go kill it. So this is very exciting because this is very different than the other targeted therapies that we've had before. And there's actually now a drug that will be evaluated in clinical trials for AML as well. But instead of targeting CD19, it'll target CD33. That same target is Vadastuximab. And last but not least, again, this is a drug that hopefully will gain its approval sometime in the near future, Inotuzomab Ozogamicin. Again, this is another type of antibody therapy, but it's an antibody that is linked to a toxin, in this case, calicheamycin. So this antibody targets CD22, again, another marker on the ALL cell surface. Same mechanism. It targets the CD22. This complex gets taken into the cell. The toxin gets released, which then causes the DNA damage and ultimately cell death. So again, when you're looking at traditional chemotherapy drugs, I usually use the analogy that we use a sledgehammer. And so you knock everything down to a very low level. You kill all of the leukemic cells, but you're also affecting your normal cells as well. With some of these more targeted therapies, our hope is that we are going to be able to more finely target these leukemia cells and have less toxicity, but with greater efficacy. Thank you.